بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين حبيبنا محمد وعلى آله وصحبه أجمعين. سعادة الدكتورة مريم مطر، مؤسس ورئيس جمعية الامارات للامراض الجينية. البروفيسور ري شودري، بروفيسور اضطرابات الحركة. الدكتور دينو دميتا، استشاري دولي في طب الأعصاب وأخصائي اضطرابات الحركة. الدكتور روبام بورغهن. الدكتورة أنا روزمان، ممرضة استشارية متخصصة قسم الأعصاب. دكتور جاي جينغ في. الدكتورة دانيا السمرائي، الرئيس التنفيذي للمستشفى كينغز كولج بدبي. السيدات والسادة، السلام عليكم ورحمة الله وبركاته. لا ننسى متابعينا أيضا في المنصة الافتراضية زوم. ينظم أصدقاء باركنسون للامارات المجلس الافتراضي بعنوان ملتقى مرضى الباركنسون بالتعاون مع هيئة الصحة بدبي، جمعية الامارات للامراض الجينية، مستشفى كينغز كولج لندن، نادي المدام، الثقافي الرياضي، برنامج شكرا لعطائك، وايضا فريق نبض الامارات التطوعي، حيث سيتم تقديم الاستشاره من الاطباء المختصين في هذا المجال عالميا لمرضى باركنسون.
Good afternoon, dear guests. We thank you all for being here today. We would like to thank Her Excellency Dr. Mariam Matar, founder and president of the Emirates Genetic Diseases Association. We would also like to thank Professor Ray Chaudhry, Professor of Movement Disorders. We would also like to thank Dr. Vinod Mehta, an international consultant neurologist and movement disorder specialist. We would like to thank Dr. Rupam Borgerheim, Dr. Anna Rosman, consultant nurse specialist in neurology, Dr. Guy Changfei, Dr. Daniel Samara, Chief Operating Officer of King's College Hospital, Dubai. Ladies and gentlemen, the attendees on the Zoom meeting as well, we would like to thank you all for attending today's event titled Friends of Parkinson's Emirates. This is for the Parkinson's patients in UAE. This event is hosted in cooperation with Dubai Health Authority, with Emirates Genetic Diseases Association, with King's College Hospital London, المدام Cultural and Sports Club. Thank you for your support, Emirates Pulse volunteer team. The consultation will be provided by the physicians specializing in this field worldwide for Parkinson's patients.
في هذه الأمسية الرائعة نحن نشكر بجميع من انضم إلينا في هذا الملتقى الجميل. أما الآن ندعو الأخ حذيفة إبراهيم، مؤسس ورئيس أصدقاء باركنسون الإمارات، فلنرحب به جميعا. تفضل أستاذ حذيفة.
We invite Brother Hudayfa Ibrahim, founder and president of Parkinson's Friends of Emirates.
Dr. Borgohen, Dr. Taichung, Dr. Daniel, Mr. Majid Al-Hassan, and all the others who have supported us, especially Dubai Health Authority, Emirates or UAE Genetic Diseases Association, King's College Hospital London, Dubai. Thanks for your giving program. المدام Club, المدام Sports and Cultural Club, and الامارات team. Thank you so much. Just to give a brief, I have been am one of the patients of Parkinson's, and I've suffered and disabled myself under this or with this underrated, undertreated condition. I've been misdiagnosed and mistreated many times. sniffed death. I remember those days when my daughter told me she can be my scribe. What I've been through these years, as the day goes by, I had to crawl. I do not want our community to suffer. I do not want anyone in our community to suffer the same way as I have, or the same way my family has. I do not want their carers to go through the hell that my family and we had been through. We need an answer, and that's the reason why we have the international Parkinson's specialists with us here today. And I would like to thank all of them for joining us today and for accepting our invitation. I'm most grateful to my clinicians, Professor Ray, Dr. Mehta from King's College London, who gave me a new lease of life. And I also want to thank Her Excellency, Dr. Mariam, who has been the spine of Friends of Parkinson's UAE, and to support me. Thank you.
كل الشكر للأخ حذيفة إبراهيم، مؤسس ورئيس أصدقاء باركنسون الامارات، حيث تحدث عن مشاركة الأطباء وأيضا الشركاء، وشكر جميع المتعاونين في إنجاح هذا الملتقى الجميل. أما الآن نتشرف بدعوة ضيوف الملتقى الأطباء، وهم بروفيسور ري تشودري، والدكتور فينود ميتا، والدكتور روبن برغهن، والدكتورة آنا روزمان، والدكتور جاي كانغ في للصعود، وهم في المسرح للبدء في تقديم الاستشارات لمرضى الباركنسون. نرحب بهم مجددا والكلمة إليه.
Thank you, ladies and gentlemen. As for now, we are honored to invite the guests of the forum. Professor Ray Chaudhry, Dr. Vinod Mehta, Dr. Rupam Bargain, Dr. Anna Rosman, Dr. Guy Cheng, and Dr. Dania to go up to the stage to start providing consultations for the Parkinson's patients. First off, I would like to invite Dr. Vinod to give us a few words regarding this event today.
I don't want to take much time, but I just want to say a few words because I've been doing, I did like 15 years of hard work and stress and strife. Actually, I trained in the Prof. Chaudhry here. We also know that God of Parkinson's. We can just do Google, the God of Parkinson's to say. So last 50 years in England, we have societies where all the communities gather together, because in the busy clinics, you see how many of you raise your hands and say you go to your doctor, and how many minutes the doctor spend time with you? 5 minutes, 10 minutes, 20 minutes, 30 minutes. Come on, anyone here? Okay, 5 minutes, yes. In that 5 minutes, you can't actually tell the doctor what you actually want. So in that 5 minutes, you can't actually express all your symptoms to your doctor. So patients with Parkinson's, they have hundreds of symptoms. They have like fatigue, they have problems with dribbling, saliva. So, but doctors are focused with on stiffness. For example, when the man himself here, who's been instrumental of for founding this prodigious society, when he first came to me, I can say that I want to share this with Prof. Chaudhry here. It's an interactive session. Rupam and Guy and Anna and our CEO, Dr. Dania, here also here. And Sheikh Uzaifa came in. I got 30 minutes in my clinic. Then he just said, could you please stop computer, looking at the computer? Could you please listen to me? I was shocked. I never looked at the computer, and I never looked. He said, I've been treated by 7 neurologists, and he was about to fly to London to see Prof. Chowdhury and myself. And actually, I need to share this Prof. Chowdhury, but we didn't have time, so I have to see him. So that's a slot. Then he came to know that King's College London, Dubai, we have like this extension of King's College London Hospital. We have like 6 hours extension where we are. Then he finally thought that, yes, I'll go and say hello to him. So when he came to me, he was literally crawling. He was stiff. His eyes was closing down, and he can't be able to speak. If we speak, he can't, the words are not coming out. And literally the head's turning to one side. And I can see his family with him holding on one side, he and holding on other side. I'm just, the why I'm explaining this is that, I've seen this in front of me happening. And he suffered for the last 3 years, being misdiagnosed, mistreated, misrated. Everyone said, finally, he'd been told to go and strike me to psychiatrist. Then he was loaded up with antipsychotics. So antipsychotics are completely contraindicated in patients with Parkinson's. So that made himself to realize he suffered a lot. So he needs to open up a society where everyone has an opportunity to interact with patients, like, with one evening. And he actually made an insight to all connected. Last visit, we formed a society, a group, a community of patients with Parkinson's disease. I need to thank Her Highness Mariam Matta, who's been a main spine, Her Excellency, beg your pardon, because she's instrumental, being a patronage for this one. And also thank our director, Prof. Chowdhury, who also very key, who also always supports these type of community programs. And we have Professor Rupam Borgain and Guy Jung-Fei. And I just want to tell you one name, Dr. Dania has been actually instrumental to bringing this, and he's always supportive. But yes, we need to do something for the society, something for the community. Yes, let's start with King's College Hospital, London, Dubai. Then perhaps this will make other people will work up with this one. And perhaps this will be a continuous affair of bringing everyone to at one shelter. So you have the opportunity to interact with Professor Chowdhury. If you call us in London, it's like 6 months appointment. If you call Rupam and Guy, and we are all here. So this is an opportunity to discuss the symptoms. And also, I just want to, when Sheikh Huzaifa was here, and he was asking me one question repeatedly, Huzaifa, doctor, are my treatment working? First question. Doctor, why is I'm taking 10, 15 tablets, and do I know which tablet is good, which medicine is best, which is causing side effects? How can I monitor? Same thing like patients with heart pain. So then we thought, yes, we want to introduce a innovative, technology-driven tool to the society, to the Arab world. Again, it's initiation of Huzaifa's to bring Prof. Chowdhury in, and Prof. Chowdhury going to share what is that monument which helps patients and doctors understand what is the right treatment for the patient. I will ask Prof. Chowdhury to take over and explain to you first. Thank you very much for giving me this opportunity.
Can we have the presentation?
So, thank you, Your Excellency. Thank you for everybody here, and all the colleagues, and Dr. Mehta and my colleagues from UK, from Poland, from India. I wasn't prepared to give a talk, and I just actually made the presentation sitting there because I think it's important to show what devices can do rather than me waffling on. And I think that's what I've done, but I need the presentation to come up.
Script over this. This is what the device looks like. It's a simple watch. You just wear the watch, and you can wear it this way or that way on the wrist, and you go away, and you're at home for 6 days wearing the watch. You can have a shower with it. You can go to sleep. You have to go to sleep with it. What it tells us is how your Parkinson's is over the next 5 to 6 days. You can never get that in a clinic appointment, which usually lasts for 15 or 20 minutes, maybe 30 minutes, where Dr. Mehta will ask you, how are you? How's your tremor? How's the movements? How are you sleeping? And that's it. And we make a judgment about a person's condition, which has been going on for years, based on those very rudimentary examination for a few minutes in the clinic. This changes all of that. This is a revolution. How is it a revolution? What does it actually do? Well, firstly, it gives you this sort of figures. If you look at this figure, you look at 2 lines. You look at the green line, which means how overactive you are, and you look at the blue line here. The blue line shows how underactive you are. Now, normally, the blue line should be at the top place here where the green is. You can immediately look at this and say, this person needs a lot of treatment. His blue line is right at the bottom, is diving at the bottom of the sea. We need to push this up. And this is true for 6 days. So this person must be really what we call bradykinetic. Again, you look at this person, very different. Both have Parkinson's. Here you look at the green line, it's all over the place. What's happening? What does this mean? This means this person is going like this all the time, dyskinetic. And that's because of over-treatment, whereas you see the blue line here is where it should be. So this device is telling us, okay, you've got the treatment right, but the person is very, very overactive. You've got to cut your treatment down. You perhaps need to think about duodopa. You need to think about deep brain stimulation, etc. Similarly, another thing, some people have real problems at night. This gives you hour by hour definition. You look at the blue line here, it's all very fine till 7 o'clock in the morning. Here's the timing. Around 7 o'clock, the blue line just dives and is now low. What is it telling us? It's telling us the person is very, very stiff, has difficulty turning in bed, probably getting up, having to pass urine all through the night. Automatically, this tells you this person's sleep pattern is really, really bad, and we need to treat that. Historically, you're not going to get this information. The device gives you that information. Another X-ray, same thing here. You see the blue line there, diving in the morning around 7 o'clock, 6 o'clock, and if you go through the night, you'll see the same pattern. And now this is how it can show changes in treatment. This is a person who has apomorphine, and I think Dr. Mehta will probably talk about or bring it to this country as well. It's injection treatment for Parkinson's. You see this is the line before apomorphine. The blue line is sort of a bit low. The green line shows some spikes, some movements, excessive movements. And this is the same person after apomorphine. What has happened? The green lines have become very stable. There's no longer those major peaks. So we have reduced the dyskinesia by this treatment. In the UK, it's absolutely critical because the people who fund this, the government, now wants to find evidence, not just because we are neurologists, we have a fashionable treatment, let's use this. No. Where is the evidence that your treatment works? Well, there is the evidence. Even more evidence is here. This person is wildly dyskinetic. Just look at the green line. And the great thing is you don't need really to be a great expert to read this. The blue lines are sort of okay, apart from here. About 9 o'clock at night, this person is having a bad off period, but otherwise he's very dyskinetic. Dr. Mehta put this patient on Duodopa. What you see is this. The blue lines are still needs to be sorted. About 1 o'clock, there's a dip, 9 o'clock, but look at the green. I'll just go back to the one before there and look now. It's different. This person's quality of life is dramatically different. The device is telling us, and this is far more important than diaries. Another example where you can see how bad these movements might be. I won't go into the detail of it because you'll get bored. So other thing it tells us is what we call non-motor monitoring. In Parkinson's, it's not all about movement. People with Parkinson's have pain. They might have mood problems. They might have constipation. They might have dribbling of saliva. They might have problems with their sleep. They might have depression, anxiety. The device can measure that too. I won't go into the detail, but this will tell you, particularly people who might suddenly fall asleep, a big risk factor if that person is still driving. You can have a road traffic accident. The device, through a specialized calculation that we have developed, is able to tell you who are the people at risk of this, what we call sudden onset of sleep. And the device can also tell you how you're sleeping. I just would like you to look at two things. Look at the black lines at the top, compare it to the black line at the bottom. If anybody can see the difference. The person at nighttime here with the interrupted black dots are waking up frequently at night. This person needs immediate and rapid treatment for the nighttime problems. Upper person is actually doing quite well. Interesting, in this particular patient, nighttime treatment was never even attempted before we did a PKG watch recording. So that's another important point. This is a calculation just to say the diaries we use are hopeless. They are totally inaccurate, largely don't work. And in my view, it's a little shocking that we have drugs being licensed on the basis of diary data. This data sort of shows that. So this is the sort of thing that we would do. We do a 6-day recording. In most of the majority of our patients, whether they have whatever sort of control they have, they can then go through the advanced therapies required. They can have it recorded after, but this is just one paradigm. And this you would be happy to hear is the last slide, which is the use of this, what we call wearable sensors, and PKG is the most established one, can lead to treatment optimization. It can lead to the better quality of life, and not just movement. It helps also with sleep, with aspects of behavior. I haven't shown you the data for that, early morning off periods, etc. PKG currently has the best validation data in the world in relation to Parkinson's. Other people say, well, I have a watch, I've got this watch. Well, every watch, you have to have it validated in Parkinson's. There are about 90 watches. That doesn't mean they have any use for Parkinson's. And this gives us remote assessment. If you are 500 miles away, you don't have to travel to see Dr. Mehta in Dubai. He can send you the watch. The recording is available virtually. By virtual assessment with the recording and tracing, he can then adjust the treatments that you might need. So this is the future, the remote assessment. That's it. This is our collaboration with the group. Oops, that's not come up. There it is. Collaboration with our group in India. We're trying to set up a big research project with Professor Rupam, who's here. He's featuring there somewhere, sitting there somewhere. Oh, there, he's next to me. And also Dr. Mehta, who's a big player there. But of course, these key people who are helping us by bringing this very important technological advance, much needed, massive unmet need for Parkinson's here. That's all I have to say. Thank you.
We would now like to give a chance to the patients who would give a chance now to the patients who would like to ask any questions. The doctors are here. نعطي الفرصة الآن للمرضى أو الأخوة اللي في الحضور إذا عندهم أي أسئلة للدكاترة. فاللي عنده أي سؤال بس يرفع يده، وعندنا دكتور بشار إن شاء الله بس بيرفعه بحيث أنه هو يقدر يتواصل مع الأطباء. دكتور بشار الكنترول عنده. هي نعم.
السلام عليكم اخوان.
السلام عليكم. لو سمحت أخي، عندي بس استفسار بخصوص الكانيتوغراف اللي كان عم يشرح عنه الدكتور خلال المحاضرة. بس كان عندي استفسار إنه كيف ممكن الجهاز يفرق بين الديسكينيتيك.
We have right now 256 attendees.
باعتباري تابعت كل المواد يعني اللي قالوا السيد الدكتور، باعتباري أنا مختص أن أعرف ما هي التأثير النفسي لمرضى باركنسون وما هي العواقب النفسية خاصة السلبية التي تؤثر على المرضى. Hello.
Professor, this question, it's more on the psychological side. He says, what are the psychological effects?
Psychological problem that Parkinson's patients have, really from the beginning, is anxiety. We now know that almost 30 to 40% of people with Parkinson's have a generalized anxiety disorder. Along with that comes mood problems, depression, and both major depression and minor depression, and anhedonia. So this is also quite a problem. But in addition, there is also drug-related psychological issues. Sometimes certain drugs prescribed for Parkinson's can also cause agitation, can also cause people to have neuropsychiatric problems such as hallucinations, confusion, and so on. So really it's a mixture of anxiety, depression, although anxiety is more common, low mood, sometimes losing the interest in doing things. We call it apathy, but along with that comes drug-related problems as well.
اخوي انا عندي سؤال للبروفيسور بعد نفس الشيء.
تفضل.
السؤال الاول، لاي اعمار ياثر لمرض باركنسون بشكل كبير؟ السؤال الثاني عن شو العلاج المتوفر في الدوله لمرض الباركنسون؟
Tamam. Doctor, Professor, this question is for you. He says, usually, like, at what age does Parkinson's affect? And second, what are right now the treatments available for Parkinson's in the United Arab Emirates?
Okay. I'll take the first part of the question, and then perhaps Vinod might be able to answer the second part better, because I don't really practice there. So, any age can be affected by Parkinson's. There is a perception that if you're young, you will not get Parkinson's, a bit like COVID-19. It's not true. Michael J. Fox developed his Parkinsonism at the age of 32. there are people in their 20s who can develop Parkinson's, but it is rare. If you survive up to the age of 80, 1 in 50 of us will get Parkinson's. If you survive up to the age of 90, 1 in 25 will get Parkinson's. So as you get older, your risks of Parkinson's rise, particularly over the ages of 75, but you can get Parkinson's in 30s, 40s, 50s, 60s, even 20s. The younger you are, the more likely it is a genetic pattern of Parkinson's. We have many, many genes now for Parkinson's. They're likely to be manifested in people who develop the condition at a very young age. Regarding the treatments that are available in UAE, perhaps Dr. Mehta will be able to answer that question better than me.
Right. Actually, when I first started here, so I maybe it's my personal. It's not. I'm not, globally taking this one. I'm just saying that it's my personal opinion and my understanding here, because all my patients, actually, I have to say, I inherited more than 91 in two visits. So out of 91 patients, 65 all are very advanced Parkinson's disease. So either A, they're on having Parkinson's for 10 years or 15 years, have been told there is no treatment for Parkinson's, or they have toured different countries and different cities and finally back to UAE. And that 67 to 69 patients, like 30 patients who have been traveled abroad to Germany, Jordan, UK, they are actually having some sort of advanced treatments, whereas patients treated locally, it's my personal experience I'm talking about, that they only have limited options. The limited options, again, because they don't have this availability of treatments here, that's what patients like Huzaifa himself has to fly to UK to get the treatment. So here, because of lack of availability of treatments, lack of awareness, lack of understanding, that's why we are actually slightly beyond to the Western world. So that's what these type of educational programs and societies coming together so that you can have an awareness. So the treatments we have in UAE at the moment was 1960, we have levodopa. 1970 and 80, perhaps Prof. Chaudhry might correct if I'm wrong, that we have other type of new treatments. In 2006, we have the new version of levodopa. So after 2006, now we're on 2020. Since 2012, we have injection treatments, infusion treatments, and there are other type of patch treatments. But my experience is now we are bringing these new treatments to UAE for benefit of the community. So last 10 years, I have to say that we have only limited options here. So the options we have now, so if we say that, forget about 10 years ago, now we have excellent treatments, which we can make, which we can give the quality of life to our patient. What else you want? Say, for example, Huzaifa himself, an example, the family wants his quality of life. If your mother or father has Parkinson's disease, what would you expect? He just stand up, eat and drink himself, dress himself and be independent. So 10 years ago, we don't have any treatments. Now we have more advanced treatments. We have a patch treatments, pen treatments, pump treatments, and pipe treatments. I think the questions are coming through. I'll pass it on to the... Anything else?
محمد تفضل.
نعم لو سمحت عندي سؤال للدكتور ري اللي كان عم يتكلم حاليا، وهو بخصوص كانت الجراف اللي كان عم يتحدث عنه في نهاية الحديث. استفساري هو مدى قابلية. نعم
الأخ محمد لحظة، الصوت مش واضح، ممكن ترفع صوتك شوي؟
الآن واضح؟
نعم تفضل.
تمام. سؤالي بس للأخ الدكتور ري بخصوص الكاينيتيك جراف اللي تحدث عنه في نهاية المحاضرة. بس كان بدي أستفسر عن إمكانية استخدام الكاينيتيك جراف في مراقبة مرضى الباركنسون هون في الإمارات، وكيفية تفريق الجهاز أو آلية تفريق الجهاز بين الموجات اللي هي الديسكاينيتيك ويفز والبراديكاينيتيك ويفز لسهولة الشرح للمرضى.
Professor, this question is for you. It's regarding the graph that you had shown during at the end of your presentation, where it says how would it help to connect the patient with the doctor, and second, how would the patient be or how would the physician be able to differentiate between both types of tremors or both types of graphs?
Yeah. So again, I think that's a very, very good question. So it's quite actually easy to distinguish between the green line and the blue line and what they show. So if somebody is dyskinetic, the green line will show these spikes that I showed you. The interesting thing is that you might be dyskinetic at home, but when you come and see the doctor, you may not be dyskinetic. So I, as a doctor, would ask you, how are you? Are you okay? So it's okay. And I'll see you like that. And I'll treat you accordingly, thinking that, okay, you might have mild dyskinesia, it's not much of a problem. In the same person, if I did the graph and I had the graph in front of me, I'd see actually, even though you're like this now at this time at 4 o'clock in the afternoon in my clinic, when you're at home, over the 5 or 6 days, I see these peaks going on. So that's the real picture. So as a doctor, then I will adjust your treatment accordingly. That's the advantage of having a 6 days monitoring versus 15 or 20 minutes with the doctor, or half an hour maybe. So that's how the device personalizes the treatment that we can provide for you. In Parkinson's, one size doesn't fit all. Everybody's treatment must be individualized. And this device allows us to do that. Second question, difference between tremor and dyskinesia. Yes, tremor usually happens when the person is very off. So the blue line will be right down, and the green line might show some shaking. Dyskinesia happens when the person is on. So the blue line is up, and the green line goes like that. So you can actually make a distinction between the two as well, quite reasonably.
Dr. Guy, I have a question for you. I have a question for Dr. Guy. It says, why do Parkinson's patients have constipation?
Thank you very much. First of all, I'd like to say thank you very much for your excellency, Mr. Chairman, and the Dubai Health Authority. It's a great honor to be here. It's a good question because a lot of patients do suffer from constipation as their Parkinson's. And the fact that it's a multifactorial cause. In other words, there are many different reasons why this can happen. Firstly, Parkinson's patients can be less mobile, particularly if their treatment isn't been optimized, so therefore they don't move as much. And that in itself can cause constipation if a patient is immobile. The second reason is because sometimes some of the medication they use, the anticholinergics, can cause constipation in the patient. So sometimes the constipation is caused by the medication. And the other reason, which I think is a more interesting reason, and it's something which Professor Chandra and I we're hoping to look at in more detail, is whether patients with Parkinson's disease also have some failure in the autonomic nervous system, which is the nervous system which also controls the function of the gut, the bowel, and that in itself may be another reason. So I think in treating these patients, it's important to find out what is the cause for it and to treat it with the right treatment. Because if you treat it with the wrong treatment, then you may not get the right results and you may cause sort of side effects.
Average person with Parkinson should drink at least 2 to 2.5 liters a day. It might make you go to the toilet quite often. I'm sorry, that's part of the problem, but it will not make you hugely constipated. Because dehydration related to Parkinson is one of the commonest causes of constipation that we also see in addition to all the problems that Dr. Chungfei Tai mentioned. So drinking water, particularly in a hot country, is really, really important to keep yourself well hydrated.
Thank you, Professor. Thank you, Dr. Jai. الأخت عائشة عندك سؤال؟
نعم أخويا.
تفضلي.
عندي الله يخليك سؤال اللي هو للدكتور مهتا أتوقع اسمه. بسأله طبعا بالإنجليش دايركت يعني، بس عقب عندي مثل كمقترح أبغي يعني. أنا فرحت وايد يوم شفت الملتقى هذا عن مرض الباركنسون. أنا عندي أبويا تقريبا 5 سنين عنده هالمرض، وما خلينا مكان أو استفسار نسأل عنه، يعني نبغي إنه بس يرد، إنه بس يضحك ويتكلم معانا، فمو بعارفين كيف. فأنا كمقترح لو مثلا إحنا عندنا الحين وايد في الامارات عندهم مرضى الباركنسون، يعني آباء وأمهات عندهم، بالخصوص طبعا فئة الرجال. فلو كل واحد يطلع في ملتقى ويتسوون يعني من هالاويرنس زياده، على اساس ان نبى الخبرات، ما نبى علاج او نبى مثلا شو العلاج لان احنا خلينا نكون واقعيين، ما في علاج انه كيور حق المرض نفسه، لكن نبى كخبره كيف تعاملوا مع امراض يعني مع مرضى الباركنسونز اللي معاهم في البيت، كيف تم السيطره، كيف مثلا اشياء مثلا انا مثلا صارت مع ابوي ما صارت مع احد ثاني. فكل واحد لو يطلع وتسوون هالاويرنس بنكون شاكرين لكم، يعني هكا مقترح يعني. بخصوص الدكتور مهتا, I just wanted to ask you, doctor, regarding the treatment for the Parkinson's patients. Actually, I have my father, he has it from 5 years, let's say, and we went to India, we went to Bangkok, and we are also treating him here in Dubai, actually in UAE, sorry. So I heard you saying about the patch treatment. Actually, we tried it, but to be honest, we could not see any improvement in his situation as a patient in the Parkinson's. But now I am hearing you are saying about the injection treatment. Can I have more details about this injection, please? And which I know that there is no a cure 100% for the Parkinson's patients. But do you have anything that at least can come back for our father to laugh and to speak with us as a normal, I don't say normal 100%, but at least to be with us like before, I mean. I don't know if you can, it's actually not a question, but more details from your side, please, that can help us in treating our father by any of your expert patients that you have it.
Right. Thank you very much. I didn't get your name, but you know it's a fantastic.
My name is Aisha.
Aisha, thank you. It's a fantastic question, and also it's actually the main reason for this interactive sessions. I will thank Zephyr, founder of Parkinson's Patients Society, UAE, Friends of Parkinson's. It's a way to get to make you to understand what are the treatments and in what way. I understood your question. First, let me tell you this way. Parkinson's disease is just like diabetes or hypertension, high blood pressure. There is no cure. You have a diabetes, there is no cure for diabetes, and there is no cure for high blood pressure. As long as you're taking the right treatment and the symptomatic control. Say for example, if you have diabetes, the problem is insulin. And if you have Parkinson's, the problem is dopamine. So the way we give that dopamine to the brain, the way you give insulin, and at right times, right doses, right mode of action,
roots, then it decides, because as you grow older, every part of your body grows, what I say that graceful aging. So same thing, as as you grow older, the dopamine starts depleting in the brain, and first 2 years or 3 years, anyone can treat Parkinson's, anyone just filling up the dopamine. But number one, to answer your question short, we need to know, is it a Parkinson's disease, or is it different? Because there are different types of Parkinson's. As Prof. Chaudhary said, one size don't fit all. So there are different sizes and different types of Parkinson's. And number one, if it is a Parkinson's, again, as was like our founder here, Zefa, has young onset of Parkinson's, where we see him like next 30, 40 years, we need to monitor him, we need to treat him accurately. Not every patient can respond to dopamine or oral dopamine. As again, I have to say that 60 to 70% of patients with Parkinson's have problem with constipation. Dr. Gai Chung Fei addressed the constipation. And because, number one, the lifestyle changes and also the delayed gastric absorption and decreased gastric motility can leads to poor levodopa absorption. That's why if you give like 20, 30 tablets, it doesn't go to the brain on time. Where the best route is to bypass the gut. Say, for example, if you want to go to the airport, would you prefer to go to the traffic, or if you have an option of by overlay and you want to go in a flyover? The same thing. The way we give the treatment to the patients with Parkinson's, if the oral treatments are working, is bypassing the gut. The way we bypass the gut is either transdermal route, that a patch, a transdermal patch, or injections or pump treatments. Injection, again, I have to say that it's a type of a treatment where it acts very quickly within minutes, and it lasts for 90 minutes or to a maximum an hour. Whereas if you see that your father gets a good response in that injection, and if it is, you don't have to take it regularly, then we can manage on oral treatment, and it can be used as a rescue in treatment. Just keep it in the pocket and start giving injection as when needed. But if you have to take it regularly, religiously, every day, 5 to 6 times, then we have to go for a pump option. So the pump is just like insulin pump. We just keep the injection and through the skin, and it goes and does the job. However, I have to emphasize that injection and the pump currently we are using as a compassionate usage program. Say, for example, if I think that your dad has, yes, he's a responds very well to injection, then we can request and we can start the treatment. If not, pipe treatment, say directly giving the treatment straight to the jejunum, and that goes to the brain, and it can last for 9 a.m. to 9 p.m. or overnight infusion as well. So number one, we need to know, is it a real Parkinson's disease or a Parkinson's mimic? If it is a Parkinson's disease, what's the dose optimization required to make your father? What all we're aiming for is to get the quality of life of your father.
معنا الأخ عامر. I have a question. This is for Professor Ray. It says, why Parkinson's patients lose their weight very fast? And what can you do to stabilize the weight of Parkinson's patients?
We also address this, but the weight loss issue in Parkinson is not really, nobody really knows the answer. This is the first thing. Like, we don't know what causes Parkinson's. But I think there's a general view that some people with Parkinson's lose weight because the appetite is disturbed because of the dopamine abnormality in the brain. Some people also lose weight because of treatment. Some type of treatment, for instance, Duodopa, has been associated with loss of weight, but after about 2 years of treatment. So it's a delayed effect. And that could be due to malnutrition because the food is not being properly absorbed from the stomach or from the part of the area where the levodopa is going into.
again, due to a variety of reasons, can be due to a bacteria sometimes called Helicobacter pylori, etc. So we don't really know the real answer, but it is a phenomenon. It could be drug induced. It could be in some people who are due to abnormality of the dopamine system. On the other hand, we see the other spectrum as well. We have people who gain weight in Parkinson. That's largely due to weight, often due to drugs. Type of drugs we call dopamine agonists, makes you eat more. And people tend to eat a lot of chocolates at night. We call it chocolate philia, first described from Dresden in Germany. They described this phenomenon in Parkinson. Some people eat a lot at night, binge eating, that results in weight gain. Others can gain weight after they've had deep brain stimulation. We have Dr. Bogahin, Professor Bogahin here. He's the king of DBS, and he will probably tell you that after DBS, some patients, not all, some, can also start gaining weight. So again, the appetite disturbance is led with various different hormones in the brain, and there's one particular hormone called leptin, which we know has been associated, as has been another one called neurotensin. So there's a very complex relationship with weight and Parkinson's. Loss of weight is more common than the gain of weight. And normally, if Dr. Mehta has a patient who has gained weight a lot, the first thing you'll find out is what is your eating behavior at night, because that's the important clinical clue. And if somebody's eating a lot at night, it's usually related to the dopamine agonist that you're taking. So it's a mixture of things.
There's a question in chat that says, do we have any statistics of Parkinson's patients in the Arab world or in the United Arab Emirates? It says, do we have any statistics data for Parkinson's patients in the Arab world or the UAE?
That's a fantastic question. I think it was the right question in front of the world leaders here, Professor Chaudhry, perhaps. Can share this and I'm going to share our views as well. Yeah, okay. Since last 10-15 years, working very closely with Professor Ray Chaudhry, and also we have like Europar, we have a collaborators on various countries in Europe, and we now started Parkinson's Research Alliance India with 10 top centers. We have led by Professor Rupam Borgain here. So we are collaborating, networking different countries because we need data so that it helps us to do research and to know that what the demographics of the condition that helps us to go to wider communities and cater to wider communities to see, say for example, I'm not sure that what's a remote patient. I've seen a patient coming in from a remote Gulf area, but they have no idea what is a tremor, what is a thing. The data-wise is very important, but to my knowledge, we don't have any data on Parkinson's genetics or Parkinson's demographics. And say, for example, so Afro-Caribbean population has different types of Parkinson's, and Asians has different types of Parkinson's. For example, Filipino patients have very young onset of Parkinson's, and we have, but coming back to Middle East, I'm afraid we don't have those demographics. I would ask Prof. Chaudhry to comment on that one, how important the data is, how important the research is. So if you don't have patients, you don't get data. It's all like vice versa. I would like to ask Prof. Chaudhry to comment on a few words of the data, what's better. Yeah, okay, Prof. Chaudhry.
Yeah, I think just to echo what Dr. Mehta said, I think research and data collection is really important. It's for two reasons. It helps us examine our practice, whether we're doing it properly or not. And secondly, it helps and empowers people with Parkinson's about what's happening with your progression. So if I collected some data sets at the beginning, if you came back to me a year or 2 years later on, I can compare with the different matrices that's been collected. And that will tell us, in some cases, how the progression has been or improvement has been. You can do that with measures of quality of life, motor, non-motor measures, etc. We do that for other conditions. In majority of other conditions, there are similar systems. And the data can be then collected in a registry, which can be anonymized. So your anonymity is protected. And they can be used for a variety of very important research that then translates back to your own care. So this is the real life translational research where the data that's captured from registry type work is then translated to the clinical practice, which then goes back to a pathway of care that provides management of treatment. So it's really, really important.
Well, I would just like to share something. Thank you so much for the question. And thank you, Professor Ray and Dr. Vinod for the answer and the information that you've shared. Once, inshallah, we're done with today's forum, hopefully by next week or the week after, we will start collecting the statistics data from the hospitals. So we have a registry or like a database of patients, what ages they are, and what type they have, what type of Parkinson's they have. Is it like the Parkinson is the early onset? What is it? And their symptoms and everything. So once we have this data, we'll be able to work on it, I think, better. Yeah.
I think that's the PKG registry.
Yes.
What Dr. was mentioning is like we do in Europe, like we do in UK, like we do in Australia, like we do in Germany, like we do in America. We actually wants to coordinate and finalize a registry of like a DHA, whatever your organization is. So they have a full control of all the Parkinson's patients. So that everything will be secured, secured and safe. So that will help to, at the source, to generate more clinical trials. And it will be a good thought and good question. And hope it's been answered. I can see a lot of patient questions coming here. I can see in front of the laptop.
We have a question here, and I think, second. Dr. Mehta, this question is for you. It says, why do Parkinson's patients drool?
Drooling.
Yeah.
Right. It's number one. It's drooling again. Hypersalivation. It depends. It's multifactorial. Say, for example, Parkinson's is a condition where it's a neurodegenerative. Everything degenerates with as part of aging. And also, Parkinson's patients, sometimes we can see problems with stiffness, can able to swallow, can have some secondary to the medications as well. So this is one of the common non-motor symptoms. Again, I have to say, professionally, like we have Parkinson's scales to validate this hypersalivation, and we have. I don't think we have this in here. Every time patients comes to us and say, Dr. Mehta, I'm having hypersalivation, I'm getting drooling. Number one, what can we do? And why? It's in part maybe due to the condition itself, where the salivary glands in Parkinson's patients, they become atrophied and it's not to do their job properly. So, and the best way is to, number one, you need to ask patients, Parkinson's patients, if you have any of your families have Parkinson's, to do a chewing gum to make sure to help with the hypersalivation. Or if they start, because if you don't do that, it's a source of infection. And you can see some patients with Parkinson's have a head shaking, the head going down. If the head is going down, that also can cause excessive salivation. And we do what we call as chemodenervation, where we inject small injections to block those salivary glands that might help with the excessive salivation. And if you don't do that one, it actually doesn't help the medications, the Parkinson's medications, to go to the brain. So I don't want to take much of the time. I can see that, because it's in front of me, there are the questions flowing through. Someone is asking about falls, isn't there?
Professor, I have a question. It says, why do Parkinson's patients fall?
A number of reasons. I think one of the commonest reasons is that as Parkinson progresses, the balance is affected, and we call it stage 3. Usually it's very rare for a Parkinson's patient to fall in the early stages of Parkinson's. And that should be a red flag. If you start your condition with falling, it's a red flag. Means the doctor has to think twice about the diagnosis of typical Parkinson's. Parkinson's patients fall later on, as I said, because of balance issues. And secondly, people might have difficulty initiating gait. In other words, the legs get stuck, but the upper body continues to move. It's called freezing. When that happens, and if you're not prepared for it, you might fall near door frames, you might fall in the kitchen, etc. So space is very important. Avoiding upturned carpets in the room or in the floor, of rough edges, all of these can lead to fall in Parkinson's. May not be in a normal person. So it's really important that the house, the belongings, and the surroundings are looked at carefully. Another really important point I always say is that dual tasking doesn't work in Parkinson's. It's because of an area in the brain called the cingulate that doesn't function very well. So as a result, if I'm walking and Dr. Mehta comes and tells me, Dr. C, you have to go somewhere, which I wasn't expecting, I will still sort of compensate for it. And I'll still carry on walking and say, Dr. Mehta, where do I have to go now? If I had Parkinson's, and if he said that to me, I will freeze. Why? Because when I'm walking in Parkinson's, I'm totally concentrating on my walking. As soon as he said something else to me, my concentration is diverted, and the cingulate, which can take in these multiple impulses, can't do that. So as a result, I answer his question, but I can't walk anymore. And when that happens, I'll fall. So always very important, a fundamental thing to tell people with Parkinson's, not to dual task. If you're in kitchen, if you're in cooking, for instance, if you want to, or if you're doing something, do it at eye level, same level. Don't go down, don't go up. If you try to do that, another reason for fall. So some things are very common sense. It's fundamentally linked to the problem of balancing issues in Parkinson's and the issue with this area of the brain called the cingulate.
Professor, I have a question. Why me?
That's a very difficult question to answer. I mean, I take your point. I mean, I know we've discussed your case. You started at the very young age of 29. It's very unusual. I think we had a question about age.
Yes.
And I simply probably, I mean, why me? I think we are all susceptible to Parkinson's. Some might be a bit more than the others. The only possible reason for that might be what we're increasingly recognizing, an interaction between environment and genetics. The two together comes to play, the epigenetic factors and the environmental factors. Environment could be anything, toxicity, insecticide exposure, pesticide exposure, multiple head traumas, etc., etc. We know that that could be a possible patterns. I think probably a mixture of, I would say, an environmental issues, which you or I may never find out. We know that genetics is not an issue in your case, but that can play a part. Possibly that. We know stress could be another factor. People who have high levels of stress are at high risk of Parkinson's. We know that. That's why it's more prominent in doctors, more prominent in entertainers, more prominent in teachers. Some are nurses, not so. So that means they're not stressed. We don't know. That was a joke. But I think it's important to recognize that it's a random choice in many ways. I don't think one can just say a specific reason, this is because of, unless somebody had a clear factor, like somebody had a bad head injury, post-traumatic. Muhammad Ali, for instance, developed Parkinson's. We can ascribe a cause in his case, etc. Certainly not in yours. I think it's a random bad luck in some ways, but it is a treatable condition. And you're chairing the session, as you can see very well.
Thank you so much. There is a question here for Dr. Rupam. If you could. It's regarding urinary problems in Parkinson's. Could you please shed some light on the urinary problems in Parkinson's?
Urinary problems are a feature of late Parkinson's usually. You don't see it in the early part of Parkinson's unless you have Parkinson's plus and you have multiple system atrophy. What you usually see is a lot of urgency and frequency. And this happens that the patient's relatives complain that in the end he's passing urine in the bed. This happens because he has freezing. He finds it difficult to get to the bed, get out of bed, and go to the bathroom in time. Even if he's able to go to the bathroom, in the way, he stops, gets stuck, and is not able to control his urine anymore, and he passes it. These problems are because of one, mobility problems, two, because he has dysautonomia, bladder problems because of an altered autonomic system. The altered autonomic system is basically difficulty in controlling the smooth flow of urine and allowing it to go smoothly. So what we normally do is we use drugs like tolterodine to control that. And this helps a lot without increasing the other effects on Parkinsonism per se. So you can try it out in the morning, one tablet if the problem is during the daytime, or give it in the evening. So these are the two ways of controlling this system of difficulty of passing urine and controlling his urine. They don't have so much of a problem in initiating the act of urination. It's usually controlling it because of lack of motor issues. Anything else? Will that be okay? I just give a little summary of that. Anything else? Can you talk a little about DBS and everything?
Sure. If you could just talk about, I have a question that's regarding surgical options.
Yeah, I can do that.
So if you could just
sure,
give a brief about that as well.
Yeah, I'll make it short.
Perfect. Thank you, doctor.
So normally we do surgery on more or less the same issues that you do the levodopa pump or you do the apomorphine. You do this after the first 3 to 5 years when you have the honeymoon period of Parkinson's treatment, which is when the patients respond very well to the medications. Then they start having more offs, they need more frequent dosages, they need more drugs each dose they take, and more combinations of drugs. So the criteria, the universal criteria that we use is that you do the unified Parkinson's disease rating scale, look at what the score is in off time, see the improvement in the on time. This gives you a very good handle on how much improvement he's going to have. So what happens is that the Parkinson's patients get worse year after year. The off score goes up year after year.
astonishingly, the on scores does not get so much worse. It does get worse. But even if 10 to 15 years later, when you actually give the medications, the patients can still respond dramatically. This happens more so with Parkinson's disease. It doesn't happen with the Parkinson's plus. Now, that's a very good handle to tell us to do surgery. Surgery is done around when the off score is around 30. Patient, if you do it early enough, if you want to delay it, you can do it much later, 10 to 15 years down the line. That's when it is normally being done. We've had studies which have given us the evidence that the earlier you do, the better the quality of life. And recently, some evidence has started to emerge that you can be actually changing the disease course by doing surgery early. It's not yet firmly established. We have the animal experimentation done in the labs showing that they get better. Now, these are things which is not done easily. There is a risk to life, about 0.5% if you do brain surgery. So it's not done easily. So that's why the other non-surgical methods are very important. They work in conjunction, and then you see which is the best way to do. You do get a good quality of life, which is the most important reason for doing surgery. And there's enough and more evidence showing that this is available. But as I said, there is a risk to life. That's why you need to do it very judiciously. You need to be very clear what you're telling the patient and their family, and they need to get their expectations, very clearly. That this is what you're going to get. You're not going to be 100% better. You're not going to stop all your drugs. Your drugs may come down by about 50%. But your on time will be longer, your off time will be less, which is what you see with other non-surgical therapies, like the Duodopa pump or the apomorphine pump. What does happen is that the off score, the difficulty that he has when he's off, that becomes less. This generally doesn't happen with other treatments. I'm talking specifically about deep brain stimulation. So it's a very difficult thing to do. The programming needs to be done carefully, judiciously, but your quality of life does improve quite remarkably. So that's what makes surgery versus non-surgical options. The pros and cons are there. You need to select what you're going to do and what the patient needs, what he deserves, and what he is expecting to get out of it. Thank you.
Dr. Anna, I have a question for you, please. If you could just join us. Shed some light on Parkinson's nurse and the role for community support.
Thank you. Maybe at first I would like to thank you for inviting me here, and as I understand, it's really positive that you realize how important is the work in the team. And the team in Parkinson's disease, it's actually much wider than only a neurologist and especially movement disorder specialist, Parkinson's disease nurse, gastroenterologists, dietitians, physiotherapists, and actually many others. But probably the core of the team is as well, the nurse is included. And why they are, the nurses, important? Because there's much support needed to the patients. For example, when they decide for advanced treatments like devices-aided therapies with the pumps, there's a lot to do even just with the devices. So the nurse is someone who's 24 hours for 7 answering the phones from the patients, helping with everyday problems that can happen and can occur anytime. Such a PD nurses needs to have the knowledge about the Parkinson's disease. They are really close to the patients, and very often the patients are more willing to tell more about the problems to the nurse than to the doctors, because usually they have more time for them and they are really in close in touch. So I think it's really good support that the nurse can give to the patients, and thanks to this, the care is really holistic, and I think the patients feel much more secured when they know there are people who cares about them. I don't. Thank you very much.
Appropriately, it's called the King's Parkinson Pain Scale, which is now used around the world. And even to make patients more empowered, we then developed a questionnaire called the King's Parkinson Pain Questionnaire. I would really like here, those of you going to your doctors, to, if you have pain, to actually raise it with the doctor and then ask the doctor to give you this questionnaire, which can be downloaded, complete it. It's just yes, no, 14 questions. You give it to the doctor. The doctor should be then able to describe the different types of pain that occurs in Parkinson's. There are many different types of pain in Parkinson's. We said body pain. One sort of pain that often happens is pain comes from inside, internal pain, and we call it central pain. Another type of pain is pain that shoots down the arms and legs. We call it reticular pain. Another type of pain we see when the drug's wearing off. So you're taking levodopa, you're taking a staligo, you're taking your madopar. After 2 hours, the drug's wearing off, the foot or the ankle turns in, we call it dystonia. With that comes a lot of pain. That's called fluctuation-related pain or wearing off pain. Another type of pain occurs only at night. People with Parkinson's get quite stiff at night, they have difficulty turning in bed at night, and that can lead to pain all around the body. So it's important that the doctor understands and doesn't put all pain into one meaningless concept of pain, but actually defines the pain, because each type of pain has its own different treatment. And you can now tell that to the doctor by completing the questionnaire called the King's Parkinson Pain Questionnaire.
Just wanted to know if there's anyone here as the attendees to ask a question. Rashid, Mr. Majid Belhassa, please.
What is actually causing the stiffness specifically? You know, what chemical? What is the reason we say stiffness overnight? What does that actually cause the stiffness overnight?
Yeah, the stiffness aspect of Parkinson's, it has many aspects, of course. It's largely driven by dopamine, loss of dopamine in the brain. So how do we know that? But if you have an animal model, and if you lesion the dopamine area part of the brain, the nigrostriatal pathway, the animal becomes very stiff. And if you then give them dopamine, the stiffness disappears. And the same thing happens in real life in Parkinson's, where the rigidity, we call it rigidity clinical practice. Once you provide a tablet with dopamine, then that's one of the first signs to improve. So that is very strictly and directly related to the dopamine system.
Since we have a lot of questions, of course, this is first of its type, the webinar that we have today. Inshallah, we'll have much more in the future. On behalf of Friends of Parkinson's UAE and the whole community, I would like to thank everyone, starting from Dubai Health Authority, UAE Genetic Diseases Association, King's College Hospital, London, and our esteemed guests, especially Her Excellency Dr. Maryam Matar and Professor Ray, Dr. Vinod, Dr. Rupam, Dr. Guy Chongfei, Dr. Anna, Mr. Majid Belhassa, and all the attendees here. And thanks for your giving program, المدام Sports and Cultural Club, and نادي الامارات team. Thank you so much. Thanks for joining us. Over to you, Brother Mohammed and Dana.
كل الشكر لكم متابعينا الأعزاء على هذه الورشة الجميلة والملتقى الجميل في مرضى الباركنسون. الامارات، كما رايتم الاجوبه من قبل الدكاتره والاستشاريين في هذا المجال والتخصص. نعتذر لاي سؤال من قبل متابعينا في المنصه الافتراضيه زوم. حاولنا قدر المستطاع ان نستجيب لاسئلتكم باللغتين العربيه والانجليزيه، وكان الاخ حذيفه يترجم للدكاتره. نشكركم جميعا. نطلب من الجميع في منصه زوم تسجيل الرابط، والسؤال الذي اتى من خلال سؤال التطوع، اي واحد مسجل في منصه الامارات للتطوع يذكر اسم رقم التطوعي على اساس يحتفظ بساعاته التطوعيه. ديانا.
So just again, a very big thank you to all of you, all of the attendees who visited us in person, all of the attendees on the Zoom meeting. We would like to give our gratitude. Thank you for being part of this. We hope that this was informative. It was helpful to all of you. As my colleague mentioned, please follow the link for more information. Hopefully this will not be the last workshop. This is only the beginning. And please follow us and stay up to date for more future workshops. And we hope to see you all soon. Thank you.
وفي الختام لا يسعنا الا ان نشكركم جميعا ونقول لكم حياكم الله. هناك مفاجأة جميلة، سوف يكون الأخ جمال بن حصى سوف يكرم من عذرا سوف يكون ساعة لمرضى الباركنسون. سوف يكون الأخ حمزة حذيفة عفوا هو أول شخص يرتدي هذه الساعة. وجود الدكتور ري وكذلك الدكتور زينود وأيضا السيد جمال بالحصى ماجد بالحصى سوف يلبسونه، وهذه الساعة سوف تقيم وتشخص حالة الأشخاص الذين لديهم حالة المرض، مرضى الباركنسون. إذا أي واحد يسأل إذا يبغى هاي الساعة كيف اشتريها؟ إن شاء الله بنرد عليكم بعد قليل. بنسأل حذيفة وإن شاء الله بنرد عليكم متابعينا عبر الزوم.
So now we will be presenting the watch, which is actually the circular time. This is one of the circular time. This is presented by Dr. Ray and Dr. Medam.
That's what it is. Okay. That's fine.
Thank you, Professor Ray. Thank you, Dr. Vinod. Thank you, Mr. Majid Balhassa. Now, Professor Ray, could you please let me know how many days I have to wear? 6 days. 6 days. Okay. And
this is basically an actigraphy type, accelerometry type device. There are many others, but we've chosen this because we have experience working with this. There are many others, like magnesium and others. We have chosen this one because we at King's have the experience with it. I'm not saying this is the watch that people have to use, but this is probably the best evidence we have.
Yeah. And also, it's a patient's choice as well. So, Uzefa preferred after showing these few tools, and it's evidence-based we have currently, which is very helpful for if Uzefa wants to know that whether the timings and medications helping or not. This will help him. And also, as you asked, that why is a stiffness? What time is a stiffness? So that will help.
I think
okay. اخواني اخواتي، بس عشان اخبركم عن الساعه هذه اول ساعه لمرضى الباركنسون، ومن خلال هذه الساعه المرضى بامكانهم ان يربطوا حالتهم او بامكانهم الاطباء يشوفون حاله المريض ويشوفون حالته على مدى 24 ساعه، وبنفس الوقت يشوفوا او الطبيب هنا بيعرف اذا المريض هل الادويه اللي هو ياخذها هل الادويه هذه فعاله او لا. وبنفس الوقت موضوع التريمرز او موضوع الحركات او الحركات اللا اراديه، هل هي كتريمر او الرعاش، او هي ديسكاينيجيا اللي يعتبر سايد افكت للادويه اللي ناخذها نحن كمرضى الباركنسون. فاشكر طبعا بروفيسور ري، واشكر الدكتور بنود، واشكر الاخ ماجد بالحصى على الساعه هذه. وبعد 6 ايام ان شاء الله، بعد 6 ايام ان شاء الله بنشوف النتائج. وطبعا نحن بما ان نحن موجودين في دوله الامارات، والاطباء ان شاء الله بيرجعون الى لندن، لكن بعد 6 ايام بيوصل التقرير لي انا من الدكاتره وهم في لندن. فكل الشكر لهم وكل الشكر لكم اخواني واخواتي على انضمامكم لهذه الجلسه الطيبه. ونسال الله تبارك وتعالى ان يجعل هذا اللقاء لقاء مرحوما، وان يوفقنا لما يحب ويرضى. والسلام عليكم ورحمه الله وبركاته.
كل الشكر لمتابعينا الاعزاء في عبر منصه زوم. ومثل ما قال الاخ حذيفه ان هاي الساعه تقوم بمراقبه الشخص المريض بالرعاش، وايضا من خلال 6 ايام سوف يراجعون الطبيب المختص لكي يرون النتائج. ختام حديثي اقول لكم كلكم جميعا مشكورين على متابعتكم، على تواصلكم. اشكر فريق العمل من خلال وجودي كاخوكم محمد ابراهيم، ووجود الاخت ديانه، ولا انسى المخرج واشراف الاخ دكتور بشار، وايضا عاصم، وايضا الاخ سيف. وكل الشكر لكم وللشركاء الذين انجحوا هذا الملتقى. الكلمه لك اختي ديانه.
So just again for the closing statement, as my colleague mentioned, thank you to all of you, all of the attendees who are with us today in person, all of the attendees who are with us on the Zoom meeting. As we mentioned, we hope this was informative. We hope you learned more about the different kinds of treatments, different kinds of stories people have had with Parkinson's. And again, we thank our brother Hudayfa for this opportunity actually to be part of this event. And hopefully we'll all be back soon to learn more. Thank you so much and have a good day, everyone. Goodbye.